I'm Anna Saucier, host of Cycle Power Summit 2019, and I'm here with Dr. Patrick Yeung Jr. Dr. Yeung is an associate professor in the Department of Obstetrics, Gynecology, and Women's Health at St. Louis University. He's founder and director of the St. Louis University Care Center for Endometriosis. He's completed advanced training in the laparoscopic excision of endometriosis, is past chair of the Endometriosis Reproductive Surgery Special Interest Group, and a member of the World Endometriosis Research Foundation. Dr. Yeung has published numerous original and review articles on endometriosis and minimally invasive surgery. Perhaps most importantly, he and his wife, who had stage 4 endometriosis, have 4 children. Dr. Yeung, it is such an honor to have you here. Welcome to the Cycle Power Summit.
Thank you so much. It's a great pleasure to be here, and thank you for doing this.
Yeah, my pleasure. So from that introduction, I don't think anybody's going to be confused about what we're talking about here today. So let's dive straight into endometriosis. First of all, what is it?
That is a great question. I like to tell patients it's where the cells which line the uterus and are shed during the period are found outside the uterus, implanted on the lining of the pelvis called the peritoneum, or the wallpaper of the pelvis. And actually, it's very timely that we're talking today because this is Endometriosis Awareness Month.
Yeah, whereas we're recording here in March.
Yeah, so this is Endometriosis Awareness Month this month. So it's very timely that we're talking about endometriosis during March.
Awesome, I love it. Now, this is one of those things that it takes a long time, that I've learned recently, it takes a long time to diagnose. I mean, I had to Google this, and when I looked it up, it looks like it takes on an average 6 to 10 years for a woman to finally be diagnosed with endometriosis. Why is it so difficult?
That is a great question. First off, just to say that this disease is very common. It's thought to be in 1 in 10 women worldwide. That's about 12 million women, at least in the US alone. So everybody kind of knows somebody with endometriosis. You may have heard of these TED Talks, and there's a TED Talk called The Most Common Disease You've Never Heard of, which I think is a great title because it really reflects how it's so common. It's up to 1 in 10 at least, up to 1 in 2 with infertility, up to 80% with pain and infertility. So
Okay.
Again, everybody knows somebody with endometriosis.
That they might not know about it, right?
Correct.
Yeah. Because sometimes you can have, and I'm sure you're going to get into this, but it's my understanding you can have a huge symptoms or very negative symptoms and have a little bit of endometriosis, but you could also have a lot of endometriosis and have no symptoms, right?
Exactly. The amount of endometriosis or the amount of disease does not line up well with the amount of symptoms. You can have a little bit of endo and a whole lot of pain, or really advanced disease, bilateral chocolate cysts, and little to no pain. That is well documented. Absolutely. But to your point, yes, there's a big delay in the diagnosis of endometriosis. This has been shown in several studies, up to 12 years from the onset of symptoms characteristic of endometriosis to the gold standard surgical diagnosis. Yeah, again, we're trying to increase awareness. People have put out there that endometriosis should be taken seriously. It is a hidden progressive disease, especially in the adolescent population, and we need to be more aware of it and pick it up sooner. Why is there such a big delay in the diagnosis? That is a great question. So oftentimes, empiric therapy is used for pain. And patients are told, well, you could take some anti-inflammatories. If that doesn't work, try some birth control pills or some kind of hormonal suppression. And ever since this Yeung study back in 1999, there has been a trend to tell patients, try this birth control pill or try Lupron which is a medication that induces chemical menopause. Actually, now it's Orilissa. You may have seen commercials for Orilissa, which has been in the news a lot. It's a new FDA-approved medication for endometriosis-associated pain. They make it sound like it's a great new drug, but it's really not a new kind of drug. It really is just oral Lupron, but it's been in the news a lot. So they'll say, take a medication like that, and if you feel better, you must have something that was hormonally active that we've suppressed. You must have had or must have endometriosis, and now you're feeling better, so it's diagnostic and therapeutic. So just stay on it. You feel better, keep it away. That's another common use of and recommendation for hormonal suppression, is to try to use it to keep endo away and stay on that until you, quote unquote, want to get pregnant. So there's a desire to put patients on birth control pills, the added benefit of birth control, to try to keep it away and to be on that and try to avoid surgery as a last resort until pregnancy.
Dr. Yeung, this is a bit of a side question, but why does that hormonal suppression work for the symptoms of endometriosis?
So if it's going to work, it's because it's kind of flooding the system with more progesterone, which is the counter hormone to estrogen. We think that estrogen stimulates endo and would thereby make the pain worse.
Okay.
So oftentimes, patients do feel better who have endometriosis associated pain. They do feel better when they are pregnant. In a similar way, now, as a side note, I hear all the time that their patients are saying that their doctor told them they should get pregnant and that would cure their endo. Could do a whole thing on the myths of endometriosis.
Right.
It's truly a myth, and a baby is not a treatment plan. And when you're no longer pregnant, you know, the pain often comes right back. Anyway, in chemical pregnancy, which is kind of what birth control pills do, they induce a kind of chemical pregnancy. They flood the system with hormones, so the body thinks it's already pregnant, so you don't ovulate. That's kind of how it works. And you might feel better when you're on it, but again, when you stop the birth control pills, the pain comes right back. Hormonal suppression has not been shown to help fertility. And hormonal suppression can actually make things worse. But if it's going to work, it's because it's progesterone or progestin, which is synthetic progesterone dominant. And maybe that suppresses the endo and helps you feel better. So at best, hormonal suppression is Band-Aid treatment or symptomatic treatment. And if you feel better, maybe that's good, but it does not diagnose the disease. It does not remove the disease. It does not help fertility. And it can actually make things worse or have severe side effects sometimes.
Wow. So it doesn't even, can the endometriosis continue to get worse as the symptoms are being treated with hormonal contraceptives?
Yes. So again, a common recommendation for using hormonal suppression is the belief that it can help prevent progression of the disease or prevent recurrence. That has not been shown to be true. In 2 recent reviews, one done by somebody else and one done by us, we came to the same conclusion that hormonal suppression, this common recommendation of using birth control pills to keep endo away, is really better thought of as expert opinion at best.
Wow.
But not evidence-based, because it's not been shown to be evidence-based. And in our study, we did not specifically recommend hormones to patients to keep endo away. They all got optimal excision, which is the way that we treat endo, is to cut it out, as opposed to just trying to destroy it with energy or ablation. And we found that the rate to finding endo again in 2 years was 0. And the majority of patients did not take hormonal suppression. So
Wow.
I and others think that what is done at surgery is the most important, and that hormones after surgery do little to kind of mop up the rest or keep it away.
Wow, fascinating. And I want to talk about those surgical techniques here in a minute. But as you were talking about the problems of endometriosis, we know that one of the ramifications, if you will, of endometriosis is difficulty in conceiving, trying to get pregnant. What are other problems that endometriosis, the presence of endometriosis causes other than difficulty conceiving? And other than those symptoms that women suffer from it sometimes?
Yes. So the two main categories of symptoms of patients with endometriosis are infertility and pain. And I'm asked all the time, how much pain is too much pain? Or when do I have to worry? Well, these are some things that I would say are red flags. So if you're taking some ibuprofen maybe on the first day or two of the period, that is one thing. But if you're doubled over in the fetal position, lying on the floor during your period, or you're missing school or work due to painful periods, you're having to book your vacations around your period, you're going to the ER a lot and they just keep telling you, oh, you must have had a ruptured cyst. You have to take narcotics to deal with your painful periods. Or, and here's a big one, you take birth control pills or some kind of hormonal suppression for the pelvic pain and do not feel better.
Oh, wow.
Those are all reasons for surgery or to suspect endometriosis. Here's a great study. This was done over 10 years ago now, which showed that in patients who took who took hormonal suppression, birth control pills for pain and did not feel better, the rate of finding endometriosis at that time was 80%.
Wow.
A few years ago, this news flash came out. I don't know that it's been published or not, but it was a follow-up study, and they basically found, again, in patients or adolescent women who took birth control or hormones for pelvic pain and did not feel better, 98% were found to have endometriosis. So failure to respond to hormonal suppression to feel better is not technically diagnostic for endometriosis, but definitely increases the suspicion for endo and would be reason for surgery. Absolutely.
Yeah, pain is our body's way of telling us something's wrong, right?
Exactly.
So, okay, so then how do we respond to that? Can you talk about, firstly, how does surgery address the problem of endometriosis?
Okay, so the surgery that is done, and it is a surgical diagnosis, even our College of OBGYN, ACOG, would say that you need surgery to diagnose endometriosis. Even better, it's a tissue diagnosis. You actually have to cut some out and get a tissue confirmation.
Meaning, I'm sorry, Dr. Yeung, but just for our audience, meaning that endometriosis truly cannot be diagnosed without surgery?
Correct.
Okay.
Again, the belief is, oh, if you feel better on hormones, you must have had endometriosis. But that is not true. And you really need a tissue diagnosis to really diagnose endometriosis. Now, you do need surgery to diagnose endo, but we do the surgery minimally invasive. So for the most part, the way we do it, it's a hole we hide in the belly button and then 2 down low in the bikini line. So it's minimally invasive laparoscopy. We call it keyhole surgery. Patients go back to work in a week or 2. So we try to do it minimally invasive, get patients back to work quickly and do it cosmetic. But it's also see and treat laparoscopy. So while it is a surgery to diagnose it, at the same time, we can usually take care of it and take care of it all. So we diagnose it and treat it at the same time. Now, most people, when they see what looks like endometriosis, the way they treat it is called ablation. They're trying to destroy the implant with energy, but nothing is removed from the body. So the problem with that approach is it can go deeper. So you might just be charring the tip of the iceberg and not get down to the bottom of the lesion. Or it could be on or near a vital organ, like bowel, bladder, ureter, vessels. And most people would not, nor should they, be burning in those areas. We cut it out. By cutting it out, we get around it, we get under it down to normal tissue, kind of under the roots. And then whatever is cut out is sent off to pathology for a tissue diagnosis. And I use a very precise non-contact CO2 laser to do that. That allows me to scallop it off even over vital structures. So we're often treating endometriosis in places where other people would not treat. So our technique is called excision, where most people do ablation. And let me just go through one quick, our study on that. So we published this paper. This is in teenagers. This is still the largest prospective study on excision in teenagers. The majority of these patients had taken hormonal suppression for the pain and did not feel better. The majority had had previous surgery and described their quality of life as awful or poor. As you can see from this graph, the blue is before, the red is after. Patients are feeling better, significantly better after surgery. But they had enough pain to want to go back to look. When we actually went to go look for endo, the number of those having endo again on repeat surgery, and that was almost half of patients in 2 years, was 0. So if it's not there, then it can't grow. And we did not tell patients that they had to be on hormones after surgery to keep it away. So if it's not there and it can't grow, then maybe we've done something good early to prevent down the road fertility. So we have shown that if you cut it out, the rate of it coming back or being missed can be very low. Whereas the published rate of recurrence after the way most people treat endometriosis, which is ablation or the burning, the rate of recurrence is published to be 50%, up to 50% in 2 years.
Wow.
Now that's quote unquote recurrence. What is probably happening is not that they're getting it all and it all comes back. What is more likely happening is they're looking back, they're seeing endo again, they're calling it recurrence and telling the patients it will always come back. But what they're probably actually seeing is disease that was never addressed or treated the time before. So they're probably really seeing persistent untreated endometriosis as opposed to really recurrent endo. And our data would imply if you actually cut it all out well in all of its forms, the rate of it coming back or being missed can be very low.
Okay, so not only are we talking about going in with minimally invasive procedures, so small holes, to put this in an easily understandable language, but then there are two methods that are generally used. Ablation or the burning has been used traditionally to just kind of take care of what's in there. You're burning it off, but nothing is actually removed. The excision, you're actually taking the tissue out of the body so that it cannot. So with the ablation is it's burned, but that can actually, the cells like proliferate into new endometriosis. Is that what happens with the ablation?
Well, you're just probably not getting it all. And then people usually would not ablate near vital structures. So
Okay.
you just have endo that's not being fully treated or is partially treated. And by cutting it out, we can make sure we get the whole thing out and treat in places where other people would not treat. So we're doing a better job of getting all the disease, we think, in somebody who is committed to excision.
Right, that's amazing. So how long has this been, and when did the excision approach start being used?
It's been around for a while, but there are very few who are actually very committed to it and do it well.
So let me ask you, Dr. Yeung, if a woman has been charting their cycles, maybe they don't have pain. We talked about that it's possible to still have endometriosis, but you're not having chronic pelvic pain, although that seems to be very common sign of endometriosis. Is it possible that, what other ways can somebody suspect or start looking into that they have possible endometriosis if they don't have chronic pain?
Great question. So the other main category of symptom is fertility. And you don't have to have a lot of pain to have endometriosis be a cause of infertility or difficulties getting pregnant. Not that these patients cannot get pregnant, but it can take longer. Sometimes if it's very advanced, it can be the main reason why they're not getting pregnant if everything is all stuck. But because up to 1 in 2 patients, even without pain, can have endometriosis when they have infertility, and because of the known benefit of surgery for endometriosis and for improving pregnancy rates, everybody back in the day who had infertility used to get a diagnostic laparoscopy to look for and treat endo. Now it's considered optional. And I've asked about that, and people readily admit it's not because there's any less benefit from surgery. It's because as long as the patient does not have a giant ball of it in the ovary called an endometrioma or chocolate cyst that would affect the stimulation protocols for IVF, they're just going to move the patient along to IVF and bypass the pelvis altogether and not have to worry about surgery. But why not try to stay focused on trying to find the problem and fix it, cut it out? The woman gets some answers for why they're not getting pregnant. The woman often feels better. And I think there's a direct correlation between feeling better and chances of pregnancy. These are billable diagnoses. I never bill infertility. We're billing pain, we're billing endometriosis, ovarian dysfunction. So these are billable diagnoses and could lead to recurring fertility. So there's many good reasons to look for the underlying reasons or causes of infertility and to go after those. And so somebody could have infertility, somebody could have cysts. Again, in more advanced forms of endometriosis, you get a ball of endometriosis in the ovary called an endometrioma or chocolate cyst. And that can affect ovarian function, and that can show up on charting. So people could have irregular or long post-peak phases, which could be a sign from the charting of cysts. So a lot, go ahead.
I want to ask you about something that you said. Did you say that 1 in 2 who have been diagnosed with infertility have endometriosis?
Yes.
Wow.
So 1 in 10 in the general population have endo. Up to 1 in 2 with infertility have endo, and vice versa. Up to 1 in 2 patients with endometriosis will have a harder time getting pregnant later. And then if you have pain and or infertility, up to 80% have endo. So again, it's so common.
Yeah.
We're trying to get the word out. It's Endometriosis Awareness Month, but everybody knows somebody with endo, and we need to do a better job with picking it up sooner and dealing with it sooner before it progresses and gets advanced.
Mm-hmm. So can you speak for just a minute? I have, and probably a lot of people have heard about ways to, I don't know, if treat or manage endometriosis without surgery. We've talked about that this excision approach seems to be the number one way. Let's just get rid of it. So, how would you speak to some other ways of managing endometriosis, or are there actual, real effective ways of reducing endometriosis or managing it without surgery?
There's ongoing research into that, and we're doing some research to try to look at that. One day maybe we'll develop a vaccine or something against endometriosis. Wouldn't that be great? But for now, the 2 main ways to manage pain are hormones and or surgery. So, the hormones can help a patient feel better, maybe, and there are different ways to deliver hormones, like birth control pills, like an IUD is a way to deliver hormones, like these medications that induce a chemical menopause. But again, all of those at best are symptomatic treatment. None of them help fertility. None of them remove the disease. And then you can actually have side effects and it can make things worse. So surgery is the only way to really remove the implants, to avoid hormones, and to help fertility. So we treat endo to help pain and to help fertility. On the pain side, there may be other sources of pain. We never promise patients that if we cut out the endo, they're never going to have pain again. And so pelvic pain centers exist to help treat non-endometriosis sources of pain, in addition to treating the endo. On the fertility side, treating endo should help fertility. But same thing, there may be other factors to optimize to help a patient have the best chances for pregnancy. And we offer a restorative fertility clinic as well for that, to help patients get pregnant together as a couple without bypassing things and without IVF. So we try to offer comprehensive services on both sides. So treating endo is an important part of treating pain and fertility, but there may be other things on both sides.
I love it. And from my own experience, we struggled with infertility for 7 years. And when my naprotechnology doctor suggested a laparoscopic surgery, we went in and looking for anything that might be wrong. And like you were talking about, in this minimally invasive surgery, they can treat endometriosis on the spot, but I imagine you can also look for anything else in there that might be off, right? At the same time.
Yeah. So adhesions can be taken down or released. If things are stuck, they can be unstuck. You can make sure the tubes are open. You can make sure the uterine cavity is clear. All that can be done to optimize the anatomy at the time of surgery. You could also look for other sources of pain at the time of surgery. So a bladder source of pain, something called interstitial cystitis, which is inflammation of the lining of the bladder, often occurs in patients with endometriosis up to 2/3 of the time. So it's another source of pain from the bladder. It's called the evil twin to endometriosis because it occurs so commonly with endo. But yes, you can look for other things and deal with them on the pain side and on the fertility side at the same time of surgery.
Fantastic. Thank you so much for that. So Dr. Yeung, in closing, I'm going to ask you, if a woman suspects that she might have endometriosis, and you talked about how there are rather few surgeons who perform this excision, what characteristics or credentials should she look for in a doctor to do this, to treat it effectively, to get rid of it?
Right. So, if somebody fails high-dose anti-inflammatories or has even tried hormonal suppression and then wants to take the next step to look for a surgeon, I really would recommend trying to find somebody who is committed to excision. We believe that is the best way to treat the disease. Napro surgeons could be a way to do that. Another great resource that gives a lot of good information on endometriosis excision, as well as provides a list of committed excisionists, throughout the country, is a Facebook group called Nancy's Nook. It's begun by Nancy Peterson, who's a nurse who herself had endometriosis. Nancy's Nook. It is by permission. You have to ask to be part of a group, but it has really grown by leaps and bounds. There's like over 55,000 members now, and they're a great resource. And that's also, and other websites as well on Endo Warriors, other places you could go to try to find somebody committed to excision in your area.
Fantastic. So Facebook is useful for finding the right kind of doctors to treat endo as well, among so many other things.
So social media can have some good use.
Exactly. Thank you so much, Dr. Yeung. At the end of all of our interviews for the Cycle Power Summit, we're asking everybody, what is your #1 cycle power tip that you would offer to our audience?
Yes. Well, I'm going to give 2 if that's okay.
Okay, go for it.
The first is that killer cramps are not normal. Padma Lakshmi is an Indian supermodel and the host of Top Chef. She herself had endometriosis. It affected her fertility. She had it cut out. She feels better. She got pregnant, but she has produced this poster to tell young women, if your cramps are killer, they're not normal, you know it, you're missing school and work, then you should get checked out and checked out sooner. So killer cramps are not normal is point #1. And point #2, which kind of ties in with that, is we really believe that getting the endometriosis diagnosed early and cut out early is the best prevention, is the best way to manage the disease before it affects fertility.
Fantastic. I want to ask you one thing from your Cycle Power tip number 1. So is that true even from the very beginning? A young girl starts her period. If she has killer cramps right away, that's not normal.
Yes, I mean, endometriosis has been found in teenagers. There was a time when people thought that you could not have endometriosis in young women, but absolutely it can be found in young women, like adolescent girls. It's probably maybe 1 in 20 or 5% in the general population of adolescents, but again, much higher in patients with pain. And that data that I showed you where teenagers took hormonal suppression for pain and did not feel better, 80 to 90% had endo.
Yeah.
So yes, it can start early. And if you have some of those red flags and you're not feeling better with hormonal suppression in particular, endometriosis can be very likely.
So helpful. Thank you so much, Dr. Yeung, for the work that you do, for helping us to get the word out there. Thank you for being part of the Cycle Power Summit.
You're kind. And again, thank you so much for everything. Keep up the good work.
Thank you.